Welcome back. We are so glad that you joined us for another episode today. And I want to thank you all for supporting us. We really appreciate all of our listeners. If you like our podcast, please tell your friends about it. And also, please give us a rating and a review to help other people find us. Now, I want to tell you how Rachel brought JJ to visit me last week. So, Rachel's youngest sister, Emily, got married, and we were all together
Yay.
for the wedding, and it was so much fun.
It was so nice. It was so much fun. And JJ, I mean, it wasn't fun getting there with him on the airplane and all the travel, but it was so fun being there. And he got to meet his uncles for the first time and his
Right,
cousin. And
right.
it was so fun just to be with everyone. And he is a huge people person already at 5
He's
months.
so
He
happy
loves
and
people.
smiley. He
Yeah,
does.
and so he did really good. We'll have to do
Yeah.
an episode about traveling.
I think you're an expert now on traveling with a newborn. I mean, getting on an airplane,
Yeah, I don't know if
traveling.
I'm an
Yeah.
expert, but I can definitely tell you what not to do. Let me
Good.
tell you
Well,
that.
perfect. Well, definitely, I think we need to do an episode on that, on traveling with
Yeah,
a
maybe
baby.
some
Yeah.
Benadryl or whiskey next time. No, I'm just kidding.
Stop.
That's not medical
Whiskey,
advice, people. Not medical
not
advice.
medical advice.
Um,
Oh,
Anyways, let's get into today's episode. I wanted to start off by saying, we started this podcast because there's so much misinformation out there, about pregnancy, childbirth, and having a newborn, and really raising kids.
yeah.
There's mommy blogs, Instagram influencers, and other podcasts too that are put out by women whose main credentials are the fact that they've had a baby. Um, or that they've seen a delivery, which,
Right.
that does, give them, they have an opinion and something that they can say, but, it doesn't really make them an expert, only in their eyes, maybe.
And I'm going to say that having personally helped thousands of women through their pregnancies and delivering, and I've delivered thousands of babies, having given
Yeah,
birth myself multiple times, I am here to tell you that no two pregnancies and no two births are alike. They're all
that's so
very
true.
different. And what might happen for you is not necessarily what's going to be right for your friend, right?
Yeah. And I mean, if you have more than one baby, even, that even the kids aren't going to be the same. They're always going to do something different so that keeping you on your toes, and your deliveries aren't going to be the same. Your pregnancies aren't going to be the same. So,
Right.
but yeah, it's our goal to give you all the most up-to-date evidence-based advice on topics related to pregnancy, birth, and raising babies. That's why we're here, to give the best medical information so you can make the best decision, and it can be an informed decision on what's right for you and your family.
Right. So, on today's episode, we're going to talk about labor inductions. Why do
Yeah.
we induce labor and how do we do it? I mean, induction of labor is one of those topics that makes a lot of pregnant women very nervous.
Mhm.
You may have heard horror stories about inductions gone wrong or about how bad Pitocin is. And hey, I understand there's concern about the cascade of interventions, which we're going to talk about later in this podcast. So I do completely understand why this topic can be so polarizing.
Yeah, and I mean, if you listen to my birth story, I didn't get induced, so I don't even, have an opinion to share on induction or how it went for me because I didn't even have to be induced. But I
Right.
have listened to some podcasts, and there's one in particular that's coming to mind that is put out by a doula. And a doula is a great resource and tool for some people, but they don't have any formal medical training. They are just a person who's attended deliveries. And, this person states in her podcast that you should never let a doctor induce your labor.
Mm.
And That's such bad advice. There are sometimes that induction is necessary for the health of the baby or the health of the mom. And I really worry that podcasts like that one just really scare pregnant women and they make you not want to trust your doctors.
Right.
If you have a doctor or a midwife that you're working with, they are trained professionals. They have been through lots and lots of training, and you picked that doctor for a reason. Hopefully, it's not just like the only doctor you could get in to see. Hopefully, you picked that person because you have a good relationship with them and you trust them. And you want your provider to be someone who's going to help you through your childbirth and allow you to have discussions with them about why things are important. So you want to be able to ask that person all of your questions. And when it comes down to it, you need to be able to trust in your medical team and your healthcare provider that they have sound medical advice.
Perfect. So, in this episode, we're going to discuss what labor induction is, why sometimes we recommend induction of labor, and then I'm also going to tell you a little bit about how we induce labor.
Okay, so let's get started. Mom,
Okay.
tell us, what is labor induction?
All right. So, quite simply, labor induction is the process of using medications or other methods to make labor start before it has started on its own. And I want to be very clear that the goal of labor induction is a vaginal delivery. Whenever we start out with a labor induction, the goal is to get to have a vaginal delivery. Currently, a little less than 25% of all labors in the United States are induced. And that number has gone up. It was about 12% in the 1990s when I was in training. So it definitely has increased over time. And overall, most labor inductions do end up resulting in a vaginal delivery. The success of an induction can be influenced by a number of factors, but to be clear, most of the time when your labor is induced, it results in a vaginal delivery. Okay.
Exactly. So, if you are a patient, you can really feel confident that if your labor is induced, most likely it's going to result in a vaginal delivery. Okay, Mom. So, why are some of the reasons that we might want to induce labor?
Okay, so actually, there are two major reasons for labor induction. The first is what we would consider a medical indication, meaning that we believe it is beneficial for the mom's health or the baby's health to induce labor. And then the second reason is something that we call an elective induction. And this means that really there's no threat to mom's health or baby's health. These inductions are for non medical reason. So that's it. We either induce for medical reasons or it's an elective induction.
Yes. So elective inductions, there's not a medical reason and no real threat to mom or baby. And they're done because the mom chooses to induce labor. Actually, I had a scheduled induction at 39 weeks before I went into labor at 37 weeks. um,
But that was for
so
medical reasons.
yeah, at 37 weeks, but 39 weeks it wasn't. That was just elective at the time.
Okay. Okay. All right. Well, you
But
didn't make it though, did you?
no, I didn't make it. So tell us, what are some reasons they might choose to induce labor if they don't have a medical reason to do so?
So, there are lots of reasons why. Our lives are really complicated. Sometimes we induce labor when a patient lives in a remote area far away from the hospital and they can't just come in when they're in labor because it's too difficult. We have that here in Alaska quite frequently, especially in the wintertime. We have people that live across the bay and they may not be able to get here urgently. Also, maybe the father of the baby works remotely, or maybe the father's in the military and mom wants to have the baby at a time when dad can be present for the delivery. So, elective inductions are done when a patient chooses to be induced. Now, I want to say we never do an elective induction prior to 39 weeks gestation. And we usually only do them if the mom has what we call a favorable cervix, and that means that her cervix is ready for labor. So your doctor or your midwife can do an exam, and based on the dilation, the effacement or thinning out of the cervix, the placement of the baby's head, we don't do them for breech babies, obviously. And whether the cervix is soft or firm, whether it's located more anteriorly or really far posteriorly in the pelvis, all of these things, we take them into consideration, and then we can determine if the cervix is what we call favorable for induction. If it is favorable, then that means there's a really great chance of a successful vaginal delivery. If the cervix is not favorable, then the chance of a vaginal delivery is less, and we usually prefer to wait and not induce unless, of course, it's medically necessary.
Right, exactly. So I've kind of heard of that when I was in med school. It's called a Bishop score, and it lets us know if labor induction is likely to be successful. And that's what we want, a successful vaginal
Right.
delivery. Yeah. So, do you ever induce someone just because they're tired of being pregnant and just want to be delivered? I'm done with this. I'm too big. I'm uncomfortable. I can't sleep. Get it out now.
So I have to say, yes, that has happened before. But again, we don't do that before 39 weeks gestation, and only if we have a really good, accurate due date. So once we make it to 39 weeks, I can be certain that we don't have a risk of me inadvertently delivering a baby before it's ready to be born. Also, if you look at all the data from millions of deliveries over years and years, it really turns out that the best time to deliver your baby is actually 39 weeks, 1 week before your due date that your doctor gives you. And that's partly because the placenta reaches its maximum efficacy for transfer of nutrients like oxygen and food to the baby. And that it reaches that maximum efficacy at about 37 weeks, and then it starts to become less effective. So, maybe there are calcifications or damage to the placenta that occurs. If you think of a placenta like a filter that filters mom's blood to give nutrients and oxygen to the baby, then it's really easy to understand that over time, filters just get junked up, right? They get plugged up and then they don't filter as well. So that's what happens. So, yes, 39 weeks and above, it is okay to induce labor. However, if your cervix isn't quite ready for induction, if it's not favorable, you may be setting yourself up for a very unpleasant induction that could last days and days. So I generally don't induce patients until their cervix is ready and they're past 39 weeks.
Gotcha. So after 39 weeks, there's not necessarily a benefit to waiting. I didn't realize
Right,
that.
right. And many, many patients still prefer to let labor start naturally. And I personally prefer to wait for labor, but it's not up to me. If the patient wants to be induced and she is past 39 weeks and has a favorable cervix, all of the data shows that there's not a good reason to wait. Baby's outcome does not improve with waiting, and neither does mom's. There was a study that was called the ARRIVE study, which was a randomized controlled trial, and that's the gold standard for scientific study. And they took women and assigned them to a group randomly, one to get intervention and the other group to not get intervention. So in this study, women were randomly assigned to labor induction versus expectant management or just waiting. They took women who were having their first baby, who were normal, low risk pregnancies without any complications, and they were assigned to either wait for labor or to get induced at 39 weeks. Now, for the babies, the 39-week induction really didn't make a difference. There was no difference in any of the outcomes for babies. But for mothers, the induction at 39 weeks was linked to a lower rate of cesarean delivery and also a lower chance of developing pregnancy-induced hypertension or high blood pressure. So, some OBGYN physicians may recommend induction at 39 weeks to their patients, and I don't necessarily agree. I think this study makes it clear that it is safe to induce at 39 weeks, but ultimately, I think it should be up to the mom. If they want to be induced, fine, but if they don't, that is also fine. So, I let the patient decide what's best for them.
Yeah, I really like that. Patients really shouldn't feel pressured about inductions. Um, Moms can be really comfortable with their decision and understand why induction may be offered, but they shouldn't feel guilty if they decide at 39 weeks,
Right.
they're just tired of being pregnant.
Right.
And,
Right.
if they're 4 centimeters dilated, which is considered favorable, and they just want to be induced, they should feel empowered to do that, like I was
Right.
going to.
Right. Right.
So the elective inductions are because the mom wants to be induced, but what are some of the common medical reasons an induction of labor may be recommended? This is a time when we recommend induction and do not recommend waiting for labor. What are some of the medical indications for induction of labor?
Sure. So usually those are the high risk pregnancies that we recommend induction. So women who have high blood pressure or women who have diabetes that have either developed during pregnancy or if they had diabetes before pregnancy. Those are common reasons to recommend a term induction of labor. And labor induction is recommended when the risk of continuing the pregnancy is greater than the risk of the induction of labor. So we know that high blood pressure, for example, can result in preeclampsia and even eclampsia, which can turn into a medical emergency for mom and for baby. So once the pregnancy is
Yeah.
full term, and that's usually 39 weeks, but in some cases, it may be recommended even sooner for patients with high blood pressure. It can it's just safer to deliver the baby than to continue the pregnancy. There are also some conditions with the baby where we may recommend an induction, like babies that have fetal growth restriction. Maybe the baby is no longer growing appropriately. And that can sometimes be because the placenta isn't functioning well to give the baby food. And at some point, it's just safer to get the baby out so we can feed the baby, right? I mean, if the amniotic fluid
Yeah.
level is low, that can be a sign of fetal compromise or any other sign of compromised blood flow to the placenta so that the baby isn't getting enough nutrition and oxygen. Those are definitely times that we recommend a labor induction.
Yeah, I've also heard that if you go past your due date, your doctor will
Mm.
recommend induction. Is that also the case?
Yeah, so we all know that 40 weeks is considered full term, and that's where the due date is assigned, right? But actually, only 5% of babies come on their due date. About 25% will go past their due date. As long as the pregnancy is healthy and there are no complications, it can be fine to go past your due date. But after 41 weeks, so that's a week past your due date, we generally do start looking a little closer at baby with a special type of ultrasound called a biophysical profile. And that lets us know that that baby is doing okay. And also by monitoring the fetal heart rate twice a week for about 20 to 30 minutes, looking for any signs of fetal distress. And as long as your baby's doing okay, and there are no signs of distress, it's really perfectly fine to wait for labor to start. Generally, we don't want patients to go more than 42 weeks of gestation because after that, there tends to be significant compromise in placental function. There's a higher risk of meconium, where the baby has a bowel movement inside. And also, there's a higher risk for fetal death in utero. So, most doctors are going to recommend induction at 42 weeks if you don't go into labor by then. Now, the vast majority of moms are going to go into spontaneous labor before 42 weeks gestation.
Awesome. So, the reason for recommending induction of labor in all of these medical indications is really to prevent the bad outcome of stillbirth.
Right.
Obviously, that's something we want to prevent. And all of the extra testing, the BPP, the biophysical profile, and the NST checks are to make sure the baby is okay and that it's safe to let the pregnancy continue. We look at all this information and then decide if it's safe for baby to stay inside or is it better for baby to be on the outside. And then that's when labor induction is recommended.
Absolutely. So we recommend induction when we think the risk of baby remaining inside is higher than baby being delivered. Now, there are some other things that we are also trying to prevent, like preeclampsia or eclampsia, like meconium fluid, with the increased risk for meconium aspiration and increased risk for infection. So when the baby has a bowel movement inside and then floats around in that, it has stool in it, right? The baby gets that fluid down in his or her lungs, and that, of course, increases the risk for complications for baby. And when the placenta really isn't functioning well, then those babies don't actually tolerate the labor process very well. So they end up being more likely to need a cesarean section to deliver them. We would prefer to deliver sooner and get a vaginal delivery than wait until the baby's in distress or until the baby needs a C-section for delivery. But of course, stillbirth is the awful thing that we're just really trying to prevent.
Yeah, I've actually seen a couple babies with meconium aspiration syndrome. It is horrible, horrible. And it can cause issues with the baby's lungs, the baby's heart. I've seen a couple babies have to go on ECMO where,
Mm.
their blood is taken out of their body and, letting their lungs and heart rest. And a machine on the outside of their body is doing that for them, which is very, very scary. So,
Mhm.
meconium aspiration syndrome is no joke. It's very, very scary. Yeah, it's horrible. So, but anyways, let's move on and talk about how labor is induced. Earlier, we talked a little bit about having a favorable cervix or a cervix that is ready for labor, but I know a lot of the times the cervix is not favorable for induction. And if that mom has a medical indication, she still might need to be induced, even though her cervix isn't ready.
Yeah, that's the case for many of our medical inductions. So, the first part of induction of labor is a process that we call cervical ripening. And that's where we get the cervix ready for labor by helping it to be softer, thinner, and also maybe a little bit more dilated. It's a remodeling of the cervical matrix where the cervix goes from being really firm and hard to being soft. It goes from being really long to being shorter. And that's a really important part of labor. When cervical ripening is done, the chances for a successful induction are significantly increased.
I do remember from my OB rotations in med school, the Bishop score of 8 or higher means the cervix is
Right.
favorable. If it's lower, then cervical ripening needs to happen first. Um, if your cervix is favorable, you have a better chance of a successful vaginal delivery. So that's where we get Bishop score of 8
Right.
equals successful vaginal delivery. But if your
Right.
cervix is not favorable, yeah, that doesn't automatically mean your induction is going to fail. It just may
Right.
mean that it will likely be a longer process because you have to do the ripening first, unfortunately. So let's talk about ripening of the cervix. How is that done?
Well, cervical ripening is typically done by one of two methods. One is a medication, a prostaglandin, and the other is using some type of a mechanical dilation process. And both methods can be effective. So, prostaglandins are a group of hormones that can help break down the matrix of the cervix and get it ready for labor. There's a gel called Prepidil, which is dinoprostone. And also, there's a little vaginal insert called Cervidil that can be placed in the vagina behind the cervix. And they kind of sit there for several hours and gradually help soften the cervix so that it will dilate easier when the contractions start. The other prostaglandin is misoprostol or Cytotec. And this is the method that I use most often because number one, it's much cheaper. And number two, it's really effective. It can be given vaginally, it can be given orally by mouth or buccally, where you put it inside your cheek and let it kind of soak in that way. It dissolves inside your cheek. And as with any medication, there can be side effects. So, Cytotec is generally considered very safe as long as the doses are spaced out at reasonable intervals. Some women will have to start. Some women will have to start some mild contractions. They After they get recurrent doses of the Cytotec, they start having contractions, and that's actually good if your goal is to get into labor. Right? It might actually get some
Yeah.
people into labor. Yeah.
Yeah, awesome. So that is the medical or the medicines that
Right.
induce or that ripen your cervix. So then you also said you can mechanically dilate. That sounds awful and horribly painful, but like tell me about those. What are they and how do they work?
Okay, they're not that bad, Rachel. So mechanical dilation work by applying gentle pressure to slowly dilate the cervix. So sometimes we use a special catheter with two balloons. I like to use something called a Cook's catheter, but some people simply use a Foley catheter like we put in the bladder to drain the bladder. Um, but the Foley catheter has a balloon on the end, and that's how it stays inside the bladder. Either way, the catheter is placed through the cervix into the uterus, and then the balloon is inflated with sterile saline. Usually, we put about 40 to 80 cc's of saline, and then it just sits there and it puts pressure on the cervix. And over time, that little bit of constant pressure just helps to dilate the cervix. Now, obviously, the cervix has to be open a little bit in order to get the catheter in. We can't put it in if the cervix is closed really tight. But if it's open even a little bit, we can get the catheter inside and then inflate the balloon.
Nice, nice. So I know that this can take some time. I remember it
Right.
can take 12 or even 24 hours or longer to get the cervix ripe for induction. The more unfavorable the cervix is when you start, the longer it can take. So if you
Right.
have a cervix that is completely closed and long, then it's probably going to take a little bit longer. It's just important to have the right expectation going in. This might take a while.
Right.
I think often patients think they're going in for an induction, and maybe they've heard an average first baby, your labor is going to be 12 to 24 hours, and they expect to have their baby within 24 hours. But
Mhm.
actually, you have to go through the cervical ripening first, and then you can start induction. And even after that, it can take a while to get into labor. But once you're in labor, then from that point, we can say 12 to 24 hours on average to have a baby.
Right. And
Takes a while.
often, if the cervix is really unfavorable, we may start with misoprostol, and then after 12 to 24 hours, we may add a Cook's catheter to continue ripening the cervix before we get to the actual labor induction. So you're absolutely right, Rachel. Just be prepared that the early part of cervical ripening can take some time.
Yeah. So if you have friends or family who are like, yeah, I was in the hospital for 3 days before she came, that,
That
might be
might be
why.
why.
Yeah.
Right.
Um, So once a patient's cervix is ripened and ready for labor, once it's dilated some and thinned out and softer, then we can start using Pitocin. I know a lot of women have heard horror stories about Pitocin. So tell us a little bit about Pitocin. What is it and why do we use it?
Perfect. You're right. So, Pitocin is the hormone oxytocin that is a naturally occurring hormone in our bodies. It causes the uterine muscle to contract. It's actually one of the most commonly used medications in the United States, and not just because of labor induction. We also give it to prevent postpartum hemorrhage. So, I mean, if you ever go to a third world country to practice medicine, like I have and Rachel has, you will
Mhm.
know that postpartum hemorrhage is a leading cause of death for moms immediately after giving birth. So, in the United States, almost every woman who gives birth in a hospital gets Pitocin right after their delivery to prevent that postpartum hemorrhage. And it works, right?
Awesome. Yeah. So, all that to say, it's not a bad drug. It actually saves so many lives. Um, but, there are risks and benefits to everything. So, one of the big issues with Pitocin is something called the cascade of interventions. Can you take a minute and explain what that means? What exactly is a cascade of interventions?
That's a great question, Rachel. So, Pitocin is an IV medication. It's given IV for safety because we can stop that IV and it has a very short half life, and the effects are out of the mom's system very rapidly. So, if we need to stop it, that can be accomplished really quickly. But because it's an IV medication, that means now the laboring mother has to get an IV and the mom has to get IV fluids. Pitocin causes the uterus to contract, and that can squeeze the baby, and that affects the blood flow through the placenta and the umbilical cord. All uterine contractions do. Since we're giving a drug that can affect the baby, we now have to continuously monitor the baby's heartbeat. So, when a mom is continuously monitored, she has to be connected to a machine, and that can mean less mobility. There are some Bluetooth monitors that are cordless, but many of the fetal monitors that are in use today still have cords attached. So the monitor is placed around the mom's abdomen and held in place, usually by this little Velcro strap around mom, and then it's connected by a cord to a monitor beside the bed. So basically, mom is tied to this monitor and really can't move around as much. Moving around, rocking on a birthing ball, taking a shower or a bath, those are great things when you're in labor, and they're severely limited and sometimes are not even possible when a mom is on Pitocin. Yeah.
Yeah, I've heard Also, I've heard some patients say they were in labor, they were doing fine, they were tolerating labor well, and then they started Pitocin on me, and all of a sudden I can no longer tolerate the pain of labor. So there's a lot of expectation in the community that Pitocin will make labor hurt more. I've heard that from so many people. So tell us about that.
Yeah, and it's because that mom that was tolerating labor well wasn't really in active labor. If she was, they wouldn't have needed to start the Pitocin to begin with. But of course, Pitocin causes the contractions to be stronger and more frequent, and that's what it's doing. It's pushing the baby out. The stronger contractions, of course, they're going to hurt more. So that mother that was doing fine in labor wasn't in active labor. Otherwise, she wouldn't have needed the Pitocin to begin with. So I do think that Pitocin causes more painful contractions than naturally occurring ones. And I'm not saying that they can't be managed. Many, many women are able to tolerate them. And of course, we have pain management options too. Of all the techniques of keeping the room dim, massage, they can help. But we have things like nitrous oxide that's available. We have epidurals for patients who desire those. So what happens is that the contractions are more painful. Mom now has to be continuously monitored, so is not able to get up and move around as much, has an IV. Then she opts for an epidural to manage the pain. And sometimes the epidural can cause mom's blood pressure to drop because it relaxes her. And then potentially the lower blood pressure of mom can affect the heart rate of baby also. So in some cases, baby doesn't tolerate the stronger contractions, especially not if mom's blood pressure drops, because that's less pressure pushing blood through the placenta to the baby. Now, thankfully, this cascade of interventions does not always happen. It is not even likely to happen, but it can happen. And this is the reason that some women are understandably nervous about starting Pitocin.
Yeah, I've heard this especially from women who want to have an unmedicated birth. It's going to
Yeah,
be harder if they get Pitocin.
right.
I suppose if you plan on getting an epidural, it's not as much of a concern. So, what are some other risks of getting Pitocin?
So the most common risk of Pitocin is something we call tachysystole, which is a fancy word for saying that there's too many contractions that are back to back. And when that happens, the uterus is literally squeezing, trying to squeeze the baby out. And it can compress the placenta or the umbilical cord, which cuts off the blood flow and the blood supply to the baby. And the baby needs that blood. That's how the baby's getting oxygen through the placenta, through the umbilical cord. So when there's a contraction, especially a strong contraction, there's decreased and sometimes not even any blood flow through the cord to the baby. That baby then is functionally holding his or her breath during the contraction. And that might be okay if the contraction lasts a minute or less and there is time between the contractions for blood to flow and the baby to recover and get that oxygen saturation back up. But if the contractions are back to back and the squeezing is constant, then there's not a chance for baby to recover in between. Now, the good news is we can turn off the Pitocin or even cut the dose in half or cut it back a little bit. Tachysystole is completely dependent on how much Pitocin is given. So if we turn it down or turn it off for a few minutes, it's out of the mom's bloodstream very quickly and the tachysystole generally goes away and baby can recover. And that's why we feel Pitocin is a very safe medication as long as we're monitoring the baby.
Gotcha. So the issues with Pitocin are dose related. The more Pitocin you get, the more risk for problems. That's what it sounds
Right.
like you're saying.
Yeah,
So that's why we have really strict protocols, right, for Pitocin,
absolutely.
for using Pitocin, for stopping Pitocin if the baby isn't tolerating labor, and for decreasing the dose
Right.
when we need to.
Right.
I know that there are IV pumps that precisely administer the correct dose, and we don't need to blast the uterus with Pitocin.
No.
We really
No.
only give enough Pitocin to get contractions that are strong enough and every 2 to 3 minutes apart. When that point's reached, we don't need to increase the dose anymore.
Right. And the point where that happens is going to be different for every woman. Some women only need a very low dose of Pitocin, and then others need much higher levels in order to achieve the same effect.
Yeah, I remember my nurses saying, you didn't even need that much Pitocin. We were only
There you
at
go.
2 or something. I don't even know
Yeah.
what the doses are, but
Yeah.
we're shocked. But I also know that sometimes OBs and midwives can break your water to help get labor going. Can you talk about that a little bit more?
Sure. Yeah, absolutely. So, amniotomy is where we artificially rupture the membranes that surround the baby. And we do this by taking a little plastic hook, placing it alongside our finger into the cervix, and then we use the hook to make a little hole in the amniotic sac. The water is going to break eventually during birth. Very rarely it happens at the very end. Most of the time, it just breaks on its own at some point during labor. Sometimes we do this in addition to giving Pitocin, and sometimes it's done separately. Breaking the water gives us a lot of information. We can see if there's meconium fluid or if the fluid is clear, if the fluid is bloody. But the real reason to do it is because the simple act of letting out some of that fluid will naturally increase the strength of contractions. Most women are going to feel those contractions pick up in intensity almost immediately after their water breaks.
Awesome. Perfect. So it can help with the induction. Perfect.
Right.
Get things moving, kick it into high gear, so to speak. So, what are
Yep.
the risks of breaking the water? Why don't you just do this on everyone to start out with?
Yeah, well, once it's done, it's done. There's no going back. Now you have to deliver the baby. You're committed. Any chance of resting, letting mom have a break and eat, get a shower, then restarting the induction are now gone. We have to keep moving forward. And that's because the longer the water is broken, the higher the risk of getting an infection, particularly if a mom is GBS positive, or if their water is broken for 18 to 24 hours or longer, the risk of infection really goes up. And that's an infection in the amniotic fluid that affects both the mom and the baby. Also, we don't want to break the water until the baby's head is engaged in the pelvis. If the head is up too high, then when the water breaks and the fluid rushes out, the umbilical cord could get swept out. And then the baby's head comes down and compresses it. That's called a prolapsed umbilical cord. And it's a true emergency because it will cut off blood flow to the baby. And that can sometimes even result in an emergency C section. So don't break the
Yeah.
water until the head is
No.
engaged. Yeah.
Yikes. Okay, that's scary. Yeah. Okay, so that's how you induce labor. Now, y- I know there are some other methods that aren't used as commonly. Um, there are a few other things I've heard patients say that can help get people into labor. One of them is membrane stripping. Tell us a little
Yeah.
bit about that.
So, stripping membranes is something that your doctor or your midwife may offer. It's not really a method for induction, but sometimes it can help you go into labor naturally sooner on your own. It can stimulate labor, but only if you're really, really close anyway. I personally don't like to do it until 39 weeks. In some cases, I may do it at 38, but anytime after 39 weeks, it's fine to do it. It's done by doing a cervical exam, and a finger is inserted into the cervix. So the cervix has to be dilated at least 1 centimeter to do this. And once I can get my finger in, I can sweep it around in a circle, and it separates the membranes from the lower part of the uterus. And that releases natural prostaglandins that can help stimulate labor, help soften the cervix. Prostaglandins, things like the misoprostol that we use for cervical ripening.
Mhm.
There's a risk of bleeding from this, but usually it's just spotting. Also, it can be a little bit uncomfortable. So sometimes a lot of patients don't want it. And I only do it if a patient wants to have it done.
Yeah, so I've heard that is the one thing I know about membrane stripping is that it is very painful. I You use the word uncomfortable. I've heard very painful.
Uncomfortable.
I've heard very
I,
painful.
I guess
I think everyone's
everyone's
different.
different.
Yeah.
Yeah, everyone's
um,
different.
I do know
Yeah,
that many women are able to tolerate it, and I have a
right,
friend who asks for it. So if she's
right.
asking for it, it must be okay. Um, but who wouldn't want to do something small like this just to go into labor naturally on their own when they're full term?
Right.
I mean, that's the goal. That's awesome.
Absolutely. And some other things that can stimulate labor. One of them is nipple stimulation. That's right. Nipple
Ooh.
stimulation causes oxytocin to be released. And that's definitely what happens after birth when that baby latches onto the breast. The issue with nipple stimulation to help start labor are that we don't really have a standard technique. Some women I know use a breast pump. Some will say just do one breast at a time and rest in between. But there's really little evidence that it can work within 72 hours for women who have a favorable cervix. It might be helpful. Yeah, like anything. There's some people that think it's fantastic and other people that'll tell you it doesn't really do much. But I will say most doctors probably aren't going to recommend it because we don't really know how effective it is. Certainly after 39 weeks, if you want to do nipple stimulation, I'm not going to stop you. Okay.
Sort of along the same lines, what about having sex? Can that help? That's what I've heard.
Actually, yes. I tell women, he got you into this mess, he can help get you out.
Yeah.
So, unless your water is broken or unless you have some other pregnancy complication like a placenta previa, you can continue to have sex right up until your labor, until your water breaks. There are prostaglandins also in semen, and that can help soften the cervix and help it to be more favorable for labor. Also, orgasm, uterine contractions, that can possibly help. The evidence is mixed again, but it definitely doesn't appear to be harmful. So I don't think there's a good reason that you shouldn't give it a try. Okay.
Yeah, and it also might help your baby daddy or your new partner, whoever you're with, happy for a little while because after you
Yeah.
deliver, you can't have sex for about 6 weeks. So get it
Yeah,
in
that's
when you
right.
can.
That's right. Another thing,
Uh,
another thing I've heard patients try is acupuncture, and there's mixed evidence on that. Some studies show that it can be helpful with cervical ripening, but there's just not a lot of data yet. Generally, it's considered safe for women who are low risk, as long as it's done by someone who's licensed and knows what they're doing.
Perfect. I've also heard some things about castor oil. I've heard people say they've tried that.
Yeah, a lot of older women, like my grandmother, would recommend this. So, castor oil is a laxative. It is a powerful laxative. It stimulates the intestines. And then, in turn, when the intestines are stimulated, they're moving all over the place, including all around the uterus. And that stimulates the uterus. There's some evidence that it may stimulate the uterus directly. I will tell you, it tastes disgusting. And many women are also going to get nausea and diarrhea when they take it. So that sounds fantastic. On that note, I think that is all we have for today. So we talked about reasons for induction, elective versus medical induction. We talked about the common methods your doctor will use for induction of labor and cervical ripening, and also some things you could try at home to help get ready for labor and maybe even get it started. This was really a great episode. I know some of you may have questions after listening to this episode. If you do, please drop us an email or message us on our Instagram, MamaDocBabyDoc. We'd love to hear from you and answer any questions you might have. But the main thing I hope you take away from this is that you should not feel guilty about your decision, whether it's to induce or not to induce. And if you do have a medical induction, just know that Pitocin can be used safely. The vast majority of women who are induced will end up with a vaginal delivery, and that is always going to be our